Today, Clozapine in 2026, what the REMS removal actually changed, and what still matters for clinicians. In late 2025, the FDA removed Clozapine's mandatory REMS enrollment requirement. What does this mean practically? Before, prescribers had to be enrolled in the Clozapine REMS program, and pharmacies required verification before dispensing. After, any licensed clinician can prescribe Clozapine without centralized enrollment, and pharmacies no longer need REMS verification. The change reflects evidence that REMS created access barriers without improving safety. The critical point: REMS managed enrollment, not clinical care. ANC monitoring requirements in the FDA label did not change. In late 2025, the FDA removed Clozapine's mandatory REMS enrollment requirement. What does this mean practically? Before, prescribers had to be enrolled in the Clozapine REMS program, and pharmacies required verification before dispensing. After, any licensed clinician can prescribe Clozapine without centralized enrollment, and pharmacies no longer need REMS verification. The change reflects evidence that REMS created access barriers without improving safety. The critical point: REMS managed enrollment, not clinical care. ANC monitoring requirements in the FDA label did not change. Absolute neutrophil count monitoring remains part of the Clozapine label regardless of REMS status. The schedule: baseline weekly for first 6 months, every 2 weeks for months 6 through 12, then monthly indefinitely. ANC thresholds: 1,000 to 1,500, mild neutropenia, continue with increased monitoring. Below 1,000, severe neutropenia, interrupt and monitor closely. Below 500, a granulocytosis, permanently discontinue, no rechallenge. Most states maintain independent monitoring programs that remain in effect. Verify your state's requirements. Clozapine is the only antipsychotic with consistent superiority in treatment-resistant schizophrenia, demonstrated in randomized trials. Yet fewer than 5% of eligible U.S. patients receive it. Why? The eye profile is significant. A granulocytosis risk about 8 per 1,000 in the first year. Myocarditis roughly 1 to 5 per 10,000, most often in the first month. Metabolic effects pronounced. Beyond eyes, monitoring requirements create friction in busy practices, and many clinicians feel unprepared to manage Clozapine's complexities. For granulocytosis occurs, the FDA label is clear: permanently discontinue. Rechallenge is contraindicated. Recurrent, potentially fatal granulocytosis risk is unacceptable. For mild to moderate neutropenia without a granulocytosis, interrupting and monitoring ANC is standard. Reinitiating at lower dose with close monitoring may be appropriate in some cases. Careful risk-benefit analysis required, ideally with hematology consultation. In 2026, Clozapine access has improved, but gaps remain. Generic Clozapine is widely available. Cost is less of a barrier than a decade ago. The REMS removal removed an administrative hurdle, but the training gap persists. Many residents complete training with minimal hands-on Clozapine experience. Ongoing debate exists about whether monitoring requirements should be further relaxed for stable long-term patients. 3 clinical pearls. First, establish baseline ANC and ECG before starting. Rule out pre-existing hematologic contraindications, non-negotiable per label. Second, start low, titrate slowly. Clozapine has a narrow therapeutic window. Many eyes, sedation, orthostatic hypotension, hypersalivation improve with slow titration. Third, build monitoring infrastructure before you start. Assign staff to track ANC results. Link refill protocols to lab confirmation. Have a neutropenia plan before it happens. 3 takeaways. The REMS removal changed prescribing access, not clinical obligations. ANC monitoring requirements are unchanged in the FDA label. Clozapine remains the most effective antipsychotic for treatment-resistant schizophrenia, but barriers keep utilization far below need. Clinicians who prescribe Clozapine must own the monitoring responsibility directly. Infrastructure must be in place before the first dose. Questions about today's content or topics you'd like to see covered in future episodes? Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.